Welcome, everybody. So as you filter in, I just want to warn you that every single session is going to start on time, on the dot. In between sessions, you'll be hearing your yacht rock, which is my choice. If you have any complaints, please come to me. But I do want to welcome you guys to the very first day of APSA. Each morning we have a daily roundup intended to provide some extra important education on some work being done, in this case by the APSA task forces. So our regular programming is going to start at 7:30 sharp with a welcome with our president, Dr. Jessica Candell. And so this first daily roundup is a product of a joint task force between the Society of Vascular Surgery and the American Pediatric Surgery Association. So members were chosen from both societies, and they met over this last year to determine areas of interest that would be common to the memberships. So one area we identified is dialysis access, and it just so happens that one of our APSA members authored a very comprehensive review that was published in Seminars of Pediatric Surgery recently. So we invited him to give an overview of that this morning. So our moderator for this session is Dr. Stephen Dunn, Chair of the Department of Surgery and Chief of Solid Organ Transplant at Nemours Children's Health in Delaware Valley.
Thank you, everyone. The star of the show today is Dr. Almond from Driscoll Children's Hospital, where he is, if I can read this, the Bruce Henderson Chair in Pediatric Surgery, the head of the Division of Pediatric Surgery, Urology, and Transplantation, and the Associate Program Director. So I think most of our time this morning is going to be taken up with Dr. Almond's presentation. There will be an opportunity for you to meet with us later. I've already told Dr. Almond that he should give everyone my phone number if you'd like to give me a call about a question about a patient so that we don't have to bother him. But he's going to share this with me. Anyway, thank you for doing it.
So, good morning. This is the QR code to the open access article that we're going to talk about today. So while you're downloading it, I'd like to thank a few people. First, I'd like to thank Dan and Casey for asking us to write this article. My co-authors, Drs. Imran, Kaler, and Alakash. And then Kathy and SVS for recognizing this need and this gap in our knowledge. And then finally, Steve and Kathy for putting this all together. So if there's a question that we don't get to today, or you have a difficult case, or you just want to come visit beautiful Corpus Christi, this is my contact information. I don't have any disclosures, but Elsevier asked us to put two on this slide. The first is to the open access article, and the second one is to their disclaimer page. So I always like to start talks with what the take-home messages are, so if you have to leave or you get tired. 50% of kids with end-stage renal disease are on hemodialysis, and the vast majority are dialyzed with a hemodialysis catheter. This is contrary to recommendations, as you'll see. I'm going to show you a 3-incision technique that you can use to place a catheter that will essentially eliminate catheter kinking. We need to know and use vein progression not only for central catheter placement, but also for fistulas and grafts. It will prolong the vascular life of the patient. We need to remember the catheter goes on the dominant side and the fistula and graft goes on the non-dominant side. And there are some arterial and anatomic requirements that you need to adhere to if you want to place fistulas and grafts. If you don't, your patency rates are going to suffer. So here is the real crux of the problem. As we all know, most vascular access is performed by adults in adults, but pediatricians will see a large number of patients that need dialysis access. So we need to know what those procedures are and how to use them. So the ideal procedure should be easy to perform, immediately usable, long-lasting, and without complications. Unfortunately, as you'll see today, and as you read in the article, this access procedure does not exist. There are several large pediatric end-stage renal disease organizations who've come together with recommendations. The commonalities of these recommendations, some of which are listed on this slide. Fistulas and grafts are preferred over catheters. Fistulas are preferred over grafts. And again, you should use vascular progression if you're going to do this work. Finally, if you're going to place a catheter, it needs to be tunneled, cuffed, and in an upper body vein. Recommendations are based mainly on weight. If your patient's less than 20 kilos, they should get a catheter. If they're 20 to 50 kilograms, a fistula, and if they're greater than 50, a fistula, and if they can't get that, a graft. Initially, about half of kids are started on hemodialysis, about a third on PD, and the remainder are transplanted. What you can see is that most patients, despite these recommendations, do not get a fistula or graft. Many things are important in the workup. Probably the two most important things are their handedness and the results of the ultrasound. This will determine where and which access procedure you perform. Indications for catheter placement include patients who need acute dialysis, and if there's a lack of training, experience, or equipment to place that fistula or graft. And finally, if the patient's going to be transplanted quickly. Here's the catheter progression that I told you about. Please remember, if you're going to put a catheter in the femoral vein or the subclavian vein, that can cause problems later. You're going to eliminate that as a future access site. In the case of the femoral vein, a transplant site. Catheter selection is quite limited, especially in young people. So I always tell people, go talk to your materials management person and find out what catheters you have for infants and small children. Catheters vary based on their tips. So from left to right, you have the taper, then the split, the self-centering, and then the step catheter. Technical tips. I don't like air emboli. So I have the anesthesiologist intubate and paralyze my patients. It seems like overkill, but I've had one, and you don't want them. You can eliminate the too long, too short problem if you measure and mark your patients. So the way I do this is under fluoroscopy. I place the tip of the catheter at the level of the right atrium, the bend in the catheter at the neck incision, and the hub near the clavicle. You have to remember that the cuff and the hub need to be in the middle of that incision. And the benefit of that is it allows you to move that catheter about a centimeter or two after you placed it. The 3-incision technique, which is in the bottom left there, will essentially eliminate catheter kinking. That third incision is made inferior and medial to 2 perpendicular lines. One is drawn laterally from the neck incision and the other superiorly from the chest incision. There are more pictures and a better description of this technique in the paper. Complications are very similar to all central lines. I guess the big thing to remember here is these catheters are big. So if they don't go easily, do not force them. Get a venogram, make sure you're in the vein you think you are, and there's no stenosis. Again, there is more information in the article about catheter placement, replacement, and how to reuse access sites. Most catheters survive about a year. Most of them have one infection, 1 or 2 catheter dysfunctions during the year, and fibrin sheath are common. I talk about fibrin sheath management in the paper also. Now let's talk about fistulas. The indication for a fistula is anybody over 20 kilos who's not going to be transplanted quickly. The most common is a radiocephalic fistula. Remember, it needs to go distally in the non-dominant arm. 3 incisions have been described for this. We prefer the longitudinal incision because it gives the most flexibility. After that is the brachiocephalic and the brachiobasilic. Each of these can be done through a transverse incision just inferior to the antecubital fossa. Some technical tips. Intraoperatively, I like to use venous dilators to make sure that the ultrasound hasn't missed a venous stenosis. I also like to flush the vein to make sure it'll tolerate arterial flow. To help prevent technical problems, I like to mark and spatulate the vein, and also to prevent stenosis, make it about 4 millimeters. The primary failure rate, primary patency rate, and secondary patency rates are listed on the slide. They're 23, 60, and 71% respectively. Intraoperative complications include stenosis, inadequate inflow, and postoperatively thrombosis and failure to mature are common. Now let's look at AV grafts. The most common indication is a child who won't take a fistula. Some technical tips, again, make sure the graft is as distal as possible, do the arterial anastomosis first, tunnel it under pressure, and then don't make it too long. We like to use 3 incisions to help prevent kinking. Primary failure rates are high, about 33%, and postoperative complications include stenosis and thrombosis. Kathy asked me to mention a couple of things about CRT and PD, so that'll be the next couple of slides. The indication for CRT is acute renal failure and one of these other indications. There's several types, including CVVH, ultrafiltration, and aquapheresis. The benefit of this form of therapy is that you can use a small catheter. It makes it very amenable to kids who are ill and small. Some people like PD instead of hemodialysis. Other people use PD in patients who've run out of vascular access or they don't tolerate it. We like to put the PD catheter on the side opposite the anticipated transplant. This keeps it away from the transplant incision. The way we do that is through a transverse incision. We remove the omentum. We use a mandarin catheter to put the catheter in the pelvis, and then we attach it to the posterior rectus sheath using a purse string suture to the cuff. We then tunnel it under the anterior rectus sheath, close the sheath over the catheter, and then test it to make sure there are no leaks and it works. You need to make the smallest possible incision to pull the catheter through. We use a tendon passer for that. To secure it to the skin, use an antimicrobial patch and a tegaderm. Do not use a suture. It will increase your infection rate. You can see that PD rates are much better than fistulas and grafts. And some of these common complications you can avoid if you just use the techniques that we talked about. Peritonitis is fairly common. It occurs about once or twice a year. So again, the take-home message is the vast majority of kids are dialyzed with a hemodialysis catheter. If you use a 3-incision technique, you'll essentially eliminate catheter kinking. We need to know and use vein progression. Remember, the catheter goes on the dominant side, the fistula goes on the non-dominant side. And then if you're going to do fistulas and grafts, you need to know what the anatomy is. Again, I would like to thank Kathy for recognizing this gap in our knowledge, Kathy and Steve for all the hard work of putting this together, and the association for allowing us to present this work. Thank you.